Okay, sir. Patient is Maggie, 42-year-old female from Alur. She has studied till 10th standard. She is a housewife. Presenting complaints: skin lesions with excoriation and itching of left lower limb 4 months back, edema 4 months, loose stools and vomiting 6 days. History of presenting illness: apparently normal asymptomatic patient noticed redness, skin lesions with pustules, excoriation followed by ulceration in her left lower limb 4 months back. After 1 week, she noticed edema initially over both her legs, facial puffiness which progressively worsened over the next 4 days, and she developed orthopnea also.
So
History of
what are the kidney diseases that can present like this following infection?
infection-related glomerulonephritis.
What is the temporal relationship between infection and glomerulonephritis?
1 week after a pharyngitis or a pyoderma, patient will develop
1 week or 2 weeks?
1 to 2.
1 to 2 weeks. And any other condition where it can be associated with infection?
IgA nephropathy, but that is sympharyngitic hematuria. Patient presents with sympharyngitic hematuria.
Sympharetic. Okay, sympharingitic. Okay, right. Then
At this point, patient also had decreased urine output. There was no gross hematuria, no history of frothing of urine, no history of dysuria, no history of fever. She gives a history of intake of over-the-counter painkiller medications for her left lower limb pain prior to the development of edema. There is no history of indigenous drug intake.
so what can be?
This can be an NSAID-induced acute interstitial nephritis as well.
Okay, right.
No history of chest pain, proximal nocturnal dyspnea or dyspnea on exertion. No history of cough. Now the patient has presented with loose stools and vomiting since last 6 days. She has passed profuse watery stools, 10 to 12 episodes per day, increasing in frequency over these days. The stool was foul smelling. However, there was no blood or mucus in stools. No history of associated tenesmus. She also had around 3 to 4 episodes of vomiting along with this, associated with nausea. Vomitus contained food particles. It was not blood stain. History of mild to vague abdominal pain was present. No history of fever. No history of any food intake from outside. She gives a history of progressive decrease in her urine output over these last 4 days. Review of systems: no history of edema, dyspnea or orthopnea at present. No history of chest pain or palpitation. No history of dysuria.
Why she
Course
was
of the
having excoriations? Why she having itching over lower limbs?
She might have had she has some skin infection which is worsened,
Infections.
or cellulitis.
Why scratching, itching? What are the medical problems where patient presents as itching? Medical cause
Uremia.
of pruritus.
Uremia,
Okay, uremia.
primary biliary cirrhosis,
Primary cholestasis. Okay.
cholestasis,
Yes. Any other condition?
polycythemia,
Polycythemia. Okay. What else? What else can have itching? Thyroid disease. Do you have itching?
Yes, sir.
Yes. What diabetes mellitus?
Yes, sir.
Okay. So your liver disease, kidney disease, thyroid disease, diabetes, hematological problems. You can have itching. So
Yes, sir.
this patient itching, which got infected, ulcerated, then she is coming with edema.
Yes, sir.
Okay, right. Okay.
Falls in the hospital. Patient was initiated on dialysis and she is delirious since last month.
Why she is initiated on dialysis? Was it a short-term dialysis or long-term dialysis was initiated?
She has, on examination, I found that she had major physical.
So
So they were planning on a long-term
long-term. So what are the common presentations of chronic kidney disease?
early presentations, clinical manifestations like
Nocturia, anorexia,
anorexia,
yes.
polyuria can be there.
Polyuria can be there, yes.
Then edema,
Edema can be there.
dyspnea on exertion, orthopnea,
Dyspnea on exertion may be there.
bone pain can be there,
Bone pain can be there. That's right.
nausea, vomiting,
So
diarrhea.
okay, fine. So patient started on possibly CKD. He's on dialysis. Okay, then what's happening?
And she is delirious since last 1.
1 month,
1 day. Last
1
1
day.
day after admission.
What are the cause of delirium?
In this patient, initially she was not delirious. So after dialysis, he has developed delirium. So this might be a dialysis disequilibrium. That's
Disequilibrium.
one.
How do you prevent that?
By a short dialysis, a short duration dialysis with
Short duration dialysis. Okay, fine. Yes, then
then this can also be uremic encephalopathy.
uremic encephalopathy is possible. Yes,
Then metabolic causes might be the reason.
yes. Is she hypertensive?
She is a hypertensive. She is a diabetic.
She was not a encephalopathy of the hypertension.
She might have an accident hypertension on admission. At present, her BPA is normal.
Normal. Okay. Okay, fine. Carry on.
Past history. Systemic hypertension since last 7 years on irregular treatment. History of 2 abortions at 20 years and 22 years of age.
At what semester?
One is first trimester and one is second trimester.
Okay.
History of type 2 diabetes mellitus since last 2 years. Patient started on OIT non-pumping. No history of CAD, PIA, CDA or pulmonary tuberculosis. Family history. History of CAD in father. Mother is alive and there is no history of any renal disease in the family. Her brother is hypertensive. No other history of any illness in the family.
So, what other renal diseases are under in families?
ADPKD is a renal disease that run in family.
Yes.
Then renal cell carcinoma can have a familial background.
Any other?
Wilms tumor.
What is Alport syndrome?
Alport syndrome.
What is that?
Alport syndrome patient presents with deafness, renal dysfunction and sensorineural hearing.
Oh, that is.
And subluxation of lens. Hearing loss, subluxation of lens and renal dysfunction.
Is it keratoconus you are talking about? Yes, yes, yes. Yeah. What is the connection between kidney disease and tuberous sclerosis?
Tuberous sclerosis can have polycystic kidney might be there in tuberous sclerosis.
What other manifestation the kidney can have in tuberous sclerosis? Leiomyoepithelioma. It's a common association of tuberous sclerosis. Now, what about von Hippel-Lindau syndrome disease?
There can be polycystic kidney in VXMA.
What are the other things you have there?
Orofacial dysmorphism might be there.
Okay. What else can be there?
Yes, can be there.
What will be the fundus examination? Retinal hemangioma.
Yes,
So he may have cerebellar hemangioblastoma. Okay. You can have renal cell carcinoma. You can have pheochromocytoma. Again, that runs in families, no?
Family.
Yes. So family history becomes important in that type of scenarios. Okay, right.
Yes, sir. Personal history. She consumes a non-vegetarian diet. Bowel and bladder habits are normal. She is not an alcoholic, not a smoker. Socioeconomic status is moderate. Drug history. History of suspected NSAID intake prior to the event 4 months back. She is on antihypertensives and OHA but non-compliant. General examination. Patient is delirious. She is, however,
So no family tree. What did you say? Is there any identical twin?
No, she has no identical twin.
Why do you want to know that?
Polycystic.
What are the benefits of having an identical twin?
So
Transplantation. So can you select identical twin for transplantation of polycystic kidney disease?
No,
Why?
no, sir.
Why? Why?
So,
Why you cannot take?
because this is an autosomal dominant condition.
So you can do genetic study on that
US
person. Potential donor must undergo genetic study.
genetic study.
So that is one indication for genetic study in suspected cases. Similarly, when you are suspecting polycystic kidney disease but imaging is not satisfactory, then again it is indicated. And when you find one is very much affected, other one is mildly affected, again you have to be very careful in making the diagnosis. So you go for genetic study. Still fourth indication for genetic study is normal sized kidneys with ultrasound showing polycystic kidneys. Then you must think whether it is a real one or not. The last part is when there is no family history of polycystic kidneys, when you make a diagnosis, genetic screening is advised. So what is genetics of polycystic kidney disease?
There are two types: autosomal dominant and autosomal recessive. Autosomal dominant kidney disease, there are suspected two genes, which is polycystic kidney disease gene 1 and PKD2. The gene 1 is in chromosome 16 and it accounts for around 78% of the cases of ADPKD. PKD2 is due to gene in the chromosome 4 and it accounts for 14% of cases of ADPKD.
Okay.
ARPKD is a suspected case in chromosome 6.
Clinically, how do they differ?
ARPKD presents at the infantile stage within 1 year of age or in utero. ADPKD presents later in second decade or so. It presents later on.
Is there a difference in the association between the two? What are associations of adult onset, adult polycystic kidney disease?
Cyst in the liver cyst,
pancreas cyst and epididymis cyst. Okay, 1. Cyst in other areas. 2. Brain aneurysm. 3. Coarctation of aorta. Okay, mitral valve prolapse, aortic regurgitation. And what about the other type, autosomal recessive type? What are the associations?
Same as
liver fibrosis is the associate, liver fibrosis association. So when you have in this mutation, which protein is playing the trick?
Polycystin.
Polycystin 1 in type 1, polycystin 2 in type 2. And what about the autosomal recessive type? What is the liver fibrosis? So fibrocystin. Fibrocystin that is producing the problem. Okay. So how do they create problems? How does the pathophysiology of polycystic kidney, how does it create problems for you? What is the problem? What are these proteins do? Polycystin 1, polycystin 2, fibrocystin. What do they do actually?
Renal cyst formation and tubular atrophy.
No. How does it usually affect? How does the cyst is produced? How does it affect the urinary calcium?
It increases the urinary calcium. There will be an increased chance of renal stones.
So usually the calcium removal will be slightly affected. Instead of going to the tubule, it goes into the interstitium, and in turn you have the enlargement of the cyst slowly developing. And what does cyst do? What does cyst do?
Cyst infections.
A cyst will be enlarging and compressing the ducts of the kidney, and that produces stasis. Stasis produces stones. Stones produces infection. Stasis itself produces infection. And how does it produce bleeding?
Bleeding into the cyst can occur because of compression.
Normally, calcium in the urine prevents the extracellular growth. When there is a diminished amount of urinary calcium, the cellular growth is increased. So it produces some amount of fibrous tissue around this area. So absence of polycystin 1 and 2 actually promotes the growth, and it produces retention of water, and cyst becomes enlarged. As cyst become enlarged, it compresses the blood vessels, produce ischemia, so renin-angiotensin system. Again you have hypertension developing. Okay, and there will be lot of angiogenesis going on the surface of the cyst. It bleeds into the cyst now and then, producing hemorrhage also. So what are the symptoms and signs you get commonly? Polycystic kidney. One is because of stones, pain. Okay, then pain can occur because of stones, infection, bleeding, or because of
then hematuria due to
hematuria or mass itself. No, can be the presentation. That's right. Okay, that's fine. That's fine. So you said about the genetics. Okay, carry on.
general examination.
General
Patient is
examination. Even now,
Patient is
now the patient delirious or okay?
Patient is delirious now.
Even now.
Yes, sir.
Yesterday she was not. What happened? What happened? Okay, patient is delirious.
She is lying down comfortably in supine position. She is not oriented to time pacer person. She is moderately built and moderately nourished. There is no pallor, interest, cyanosis, clubbing.
No pallor. What do you expect
No
pallor in this patient or not? Chronic kidney disease.
In a CKD patient, we expect pallor. But on examination, this patient was found to have a renal mass. So this is probably a polycystic kidney disease. In polycystic kidney disease, usually there will be polycythemia.
Polycythemia. Or if you give erythropoietin in a chronic kidney disease, what will happen?
There will be erythropoietin deficiency in CKD. So supplementation of erythropoietin will increase anemia to an extent.
What are side effects of erythropoietin?
One is polycythemia.
That's right. So this patient may be on erythropoietin. We do not know. We do not know. Okay, right.
Head to toe examination revealed.
No head to examination. You say general examination is head to toe. Don't use the word head to toe. General examination is good enough. Don't use the word again, eh? Examination also don't say head to toe. General examination.
Okay, sir. Patient has elongated facies. She has protruded teeth, high arched palate, Lindsay nails, and brachydactyly. Her middle finger, ring finger, and index finger are shortened, and in the toes also her second toe, third toe, and fourth toe are shortened.
What are these points indicating to you?
This might be a congenital abnormality.
Congenital abnormality may belong to some syndrome. So, is there any tuberous sclerosis in this patient?
No.
What do you expect in tuberous sclerosis if you examine the hands?
I look for sharpening patches.
No, nails.
Nails. There will be periangle keratosis.
Subungual fibromas. Subungual fibroma may be seen. So you look for that. You haven't got it. Okay. No. So she is not anemic. He is not cyanosed. He is not clubbed. No. Okay.
She has dry scaly skin, and there is a healed wound scar on the left lower limb around 2 to 3 centimeters. Her hair is normal. Thyroid and breast is normal. Pulse 80 per minute, regular in rhythm, normal in volume and character, no radiofemoral delay. Left side there is radiocephalic AV fistula, which is backdated, and there is thrill. All other peripheral pulses are equally bilateral.
Why do you want to check all peripheral pulses in this case?
The macrovascular complication of diabetes, there might be.
The duration of diabetes is 2 years.
Diagnosed since last 2 years.
2 years, so it is not yet time. Yes. Any other reason why you are looking for the lower limb pulses?
She has.
We already said there is an association with the quadratus aorta.
Yes,
okay.
Yes,
there is a fistula, no?
Fistula.
Is there a fistula functioning?
Fistula is functioning.
How do you know? How do you know?
I felt thrill on
thrill. Is this fistula mature? How will you know fistula is mature or not?
One is duration of. It should be around 2 months duration, and there should be a thrill on palpation.
No, thrill indicates a functional status, patency. When do you say it is a mature fistula? It must be palpable like a thickened blood vessel, artery like. It must get
Yes, sir.
arterialized. Then you say it is mature. Even if after 2 months, 3 months, it may not mature, in which case you cannot use it.
Yes, sir.
So whenever you get a fistula, always talk about maturity and functional status.
Yes, sir.
Is
Okay,
there
sir.
edema?
No edema.
No edema. So okay, carry on, carry on.
Blood pressure is 140/90 millimeter mercury by
Is it okay? Is
200
it okay?
Yes, sir.
What's your target in a case of chronic kidney disease? Blood pressure.
In less than 55 years, 140,
Okay, chronic kidney disease, what is your target blood pressure?
138,
In a diabetic patient, what's your target?
130/85,
Diabetes with kidney disease, what's your target?
130/80. Yes.
And diabetes with hypertension and kidney disease, what's your target? Hmm? So 140/90 is obviously abnormal, and we need to reduce it still further.
Yes,
Okay.
sir.
Hmm.
Yes, sir.
Then
The patient is febrile. Abdominal
wait
examination.
a minute. In a chronic kidney disease, what are things you specifically look for in the general examination?
Um,
Anemia and polycythemia, important
facial
finding. Second
facial
finding is
puffiness.
edema. What does edema
Um,
indicate?
edema indicates a fluid overload
Fluid
state.
status. Okay. Third thing is you have to comment about the encephalopathy part. Is this having
Yes,
patient
sir.
having encephalopathy?
This patient is delirious. She is having encephalopathy,
Encephalopathy.
and
And does she
she
have
is dry.
flap?
There is no edema.
Does she have flap?
No flap.
No flap. Does she have any uremic frost? The skin examinations, uremic frost.
She has dry, scaly
No,
skin.
that's all. No frost. Are there any scratch marks?
No scratch marks.
Okay, are there any side effect of any drugs used?
There is no drug eruptions or
Which drug you are talking about? Common drugs used, steroids, kidney patients on dialysis,
still.
cyclosporine. What side effect you look for cyclosporine?
Hemorrhagic.
Gingival hyperplasia, hypertrichosis, systemic hypertension. Hmm?
Okay.
So, okay. Abdomen examination, what did you get?
On inspection, abdomen is non-uniformly distended. Flanks are full. Right side more than left side. All quadrants move equally with respiration. Umbilicus is central and inverted. There are no sinus or dilated veins. No visible pulsations. Hernial orifices are normal. External genitalia is normal. On
Circumference of abdomen, upper segment, lower segment. Okay, carry on, carry on.
On palpation, there is no local rise of temperature, no tenderness. A mass is palpated in the left lumbar area, around 13 into 6 centimeter in size. Another mass is palpated in the right lumbar area, 12 into 5 centimeter in size. Both suggestive of renal mass. It moves with respiration, bimanually palpable, dilatable. Surface and borders are regular, no nodularity appreciated, no renal angle tenderness.
Okay, and what is the direction of these masses?
These masses are vertically placed.
Vertically placed. Okay, what are the borders like?
Borders are regular,
No, border can never be regular. Borders are described as sharp or rounded.
rounded borders.
That has to be description. Why do you
Yes,
want?
sir.
Which condition you get sharp borders?
Mm,
Spleen and liver.
uh,
That is your differential diagnosis here. Is there any splenic notch?
no splenic notch
Can you
and
get
does not
above the
cross.
swelling?
I can get above the swelling and
Swelling,
it does not cross midline also.
midline also. But you said they are moving. How to explain that?
Kidneys move with respiration though there is a restricted mobility.
So,
Compact
what is the
spleen.
difference between the movement of the spleen and kidney?
At the end of spleen moves at the end of inspiration.
Just reverse. Spleen starts moving from the beginning of inspiration.
Inspiration. Yes, sir.
Kidney moves at the end of inspiration.
Inspiration.
Okay.
Okay.
So you think it's a bilateral kidney mass. What's the
Yes,
reason
sir.
for this kidney mass?
palpable kidneys are seen in polycystic kidney disease.
One condition, okay.
Then it could be a bilateral renal cell carcinoma.
Bilateral renal, very, 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 very rare. Very, very, very rare.
Then it could be an obstructive hydroureter necrosis.
Obstructive hydronephrosis is okay. So if it's a polycystic kidney disease, is it type 1 or type 2?
Because she is she has an age of 42, this might be type 1.
This is polycystic type 1. Okay. So CKD before 54 years in one family member means polycystic kidney type 1.
Type 1.
Yes. If when do you suspect type 2?
In a child or
no, child you get a autosomal recessive. No, adult onset, autosomal dominant, type 2, how do you suspect? If a known case of polycystic kidney disease is surviving more than 74 years without CKD, then you suspect this patient also may be having type 2. Okay, that's how do these people die?
See, because of end-stage renal disease, they progress into CKD, renal failure, and that is what.
Any other cause for
then
death?
Then there could be associated barianuria.
Subarachnoid hemorrhage, yes. What are cardiac associations you have? Any other? Mitral valve prolapse, aortic regurgitation, and cardiac failure can be another cause of death. Okay. Any other problems they can have?
They can have liver cyst.
Okay. What are the complications locally in the kidney? How do you recognize infection?
She presents with abdominal pain.
Mm-hmm.
And there will be renal angle tenderness.
Yes. Any other way to confirm it? Will you do the urine culture?
She can have isolated cyst infection as well.
So urine culture may not be negative. So if he is suspecting infection, what antibiotic will suggest?
Gram-negative coverage.
Gram-negative coverage is possible. Which antibiotic will cross into the cyst? Can I give some cephalosporins or penicillins, streptomycin, aminoglycosides? The drug of choice in these patients are quinolones or vancomycin. Basic principle is there must be lipid soluble ones.
Yes, sir.
Lipophilic drugs easily cross the cyst and reaches there. What are other complications?
Hemorrhage into cyst rupture.
Hemorrhage into cyst. So how do they manifest?
With acute abdominal pain.
Acute abdominal pain. So what will you do?
We can feel mass palpable per abdomen with a
tenderness may be there. So what's the treatment of choice?
Aspiration might be required.
Aspiration may be required in certain cases. Any other complication you can have?
Cyst infections.
Infection you said, and bleeding you said. Any other?
Cyst
rupture can occur rarely. Yes. Any other? Stasis produces what?
IVC obstruction.
Stones. So I will recognize stones.
Acute abdominal pain, renal colic,
ultrasound. So what is the investigation in a suspected case of polycystic kidney disease? What are the investigations you plan?
Routine blood investigation.
Okay. Urea, creatinine, electrolytes. Okay. Then how will you confirm?
Ultrasound.
Is it always possible? There's some criteria. Sometimes criteria may not be satisfied. So what do you do next? Any other imaging modalities you can have? MRI, CT may be done to confirm. Okay. Especially if there is asymmetry in the size of the two kidneys, number is not definite in the one. Suppose the son of this patient asks you, am I having polycystic kidneys? What is your reply?
After 20 years of age,
20
the
years of
USG
age,
is to be done.
USG
is to
has
be
to
done.
be done.
Done.
And this patient wants to have a child, what will you do?
Genetic counseling is required.
Counseling is done. What is that counseling?
There is a possibility of vertical transmission. Around 50% of hospitals will
50%.
be affected.
So, but still there is a chance of 50%, no?
Yes, sir.
So, how will you protect them?
We can do a genetic study, amniotic fluid sampling, or genetic study can be done.
So, once already there is a baby inside, what's the benefit of doing amniotic fluid study? You have to terminate, no? Is it your plan, or can you do something before implantation? So, peri-implantational genetic screening has to be done, and you have to avoid such pregnancies.
Yes, sir.
Okay, so that's how you plan for the next generation. And what are the indications for how will you recognize this brain aneurysm?
Um, MRA,
Eh,
MR angiogram.
MR angiogram. So, what are the indications for doing MR angiogram?
If there is a family history of CVA in a patient with ATP kidney.
Subarachnoid hemorrhage. Okay, you have to do it. Very good. 1, 2. The patient has got a past history of subarachnoid hemorrhage. You may do it. Okay. Then people who are going for high risk job like a pilot,
Okay.
before undertaking risky jobs, you have to screen whether this patient has got or minimal amount of doubt about CVA. The screening can be done. So there are 4 indications for doing the angiogram. So how are you going to treat this patient with a suspected confirmed case of controlled
control the hypertension,
hypertension?
and then we treat infections if there is
Treat infection. Yes, okay, treat infection. We
then
said
USG guide the aspiration of cystic
aspiration sometimes here too, and control the pain, control the hematuria. Anything else?
Then we'll have to plan for renal replacement therapy.
Renal replacement therapy is planned. So that is not success. How long will continue?
Then once a patient is, if conservative management is not
Can you do the transplantation? Is there option like that?
yes, sir.
Yes, there is option. Is
Yes.
there? Yes. Okay. Now, are there any medicines that can slow down the progression of the adult onset polycystic kidney disease?
Tolvaptan.
How does it act?
Proven. It activates the B2 receptors and
So, what's happening to vasopressin in case of polycystic kidney disease? What happens to what are the levels of vasopressin in these patients?
increases vasopressin.
Vasopressin increases. So, what is the effect of vasopressin? Increases concentration or decreases concentration?
It increases concentration. There is increased free water clearance.
So, increased free water clearance means urinary concentration is increased or decreased?
Urinary concentration is decreased.
That's right. Urinary concentration is decreased. That's right. So, the tolvaptan may be having a role in these cases. Yes. Just a minute.